Welcome, and thank you so much for joining us today for our discussion on treatment. I am Dr. John Stone. I am the Executive Chairman of the IgG4ward Foundation, and it's a great pleasure to welcome you to our Fireside Chat today. Today, we're going to do something new. We're going to have a conversation on treatment, really focusing on treatment. And the intention here is to do two things. First, we want to give you a glimpse into the minds of physicians who are thinking about how to approach the treatment of IgG4-related disease. And the second is, we want to give you a chance for the first time in the history of our foundation's Fireside Chats to ask questions live. So after we go through some videos and some other questions that you've already sent in, we'll give you the opportunity to raise your hand and actually ask your question, vocalize your question live. And we look forward to that very much. So I'm delighted to be joined today by two wonderful colleagues, Dr. Arezou Khosroshahi from Emory University and Emory University Hospital, and Dr. Guy Katz from Massachusetts General Hospital and Harvard University. You probably know them both very well from their previous contributions to Fireside Chats. And we're going to show some videos of a conversation that Arezou and Guy and I had several weeks ago in this building here, the Ether Dome in the Bullfinch building at Massachusetts General Hospital. It's a famous historical place. It's the place where ether was first administered as a surgical anesthetic way back in 1846, making it possible for us to perform surgery now without having the patients experience pain. So it was a great day in the history of medicine. And this is where our conversation took place several weeks ago, rather. And I wanted to start with our mission statement. The mission of the IgG4ward Foundation is to enhance lives through education, awareness, and research, and to serve as a trusted source of truth about IgG4-related disease. And a few announcements. We are delighted to announce, we announced this several weeks ago, but I remind you here that we are having our second in-person gathering, our second in-person jamboree or jam. This is called the PeachJAM, and Arezou is going to be hosting us in Atlanta at the Emory Conference Center, right on the campus of Emory University. I'm an alumnus of Emory, and Atlanta is my hometown, so I'm very excited to be going back to both of those places. The Emory Conference Center is a wonderful venue, and it's going to suit our purposes very well. My blood is still pumping with the endorphins from the first jam that we had in Virginia back in November. So this is going to be a wonderful follow-up to that, and you'll be hearing more about the agenda for the jam in the coming weeks. The landing page will be open very soon for registration for the PeachJAM. So be alert to that. We'll send notifications out through social media, letting you know when you can begin to register. I also want to call your attention to some new resources on our website. Catherine Provencher, our Director of Advocacy and Community Outreach, has done a wonderful job updating our website. And last month, in May, the first edition of our newsletter went out, and you can take a look at that. It's saved on our website in our Education and Resources section. And there is also a new mental health resources hub that you can access through the Education and Resources page. Finally, I want to give you an update on where we are with an app that we have developed called IgG4 Me. We mentioned this several weeks ago, and the app is now just about ready to go live. It was developed for patients and for caregivers, and the design, the intention is to help patients and caregivers, people living with IgG4 related disease, whether they have it or whether a loved one has it, help them track information about their disease. It can be used on one's handheld device. It can be used on a laptop computer, and we think it's going to be a terrific asset for the IgG4 related disease community. This is probably going to be released the second half of June, and so look forward to communications about that. This is an example of some of the things that one will be able to track in IgG4 Me. There will be a flare log, so one can track the symptoms and signs of a disease recurrence. It will be useful to track the dates of infusions. How many times have you been at your doctor's office and can't quite remember, and neither can she or he remember the last time you were treated with an infusion or any kind of treatment? So the app will allow you to track that. It will allow you to track your labs. You can customize the labs that you want to track. If you want to track your IgG4, you can do that. If you want to track IgE, you can do that. If you want to track complement values, you can do that as well. It'll allow you to keep track of your medication history and your vaccine history. That is increasingly important. So we're looking forward to the release of IgG4 Me soon. And a couple of notifications about upcoming Fireside Chats. Next month, we'll do something new. We have talked about retroperitoneal fibrosis before quite a lot on these Fireside Chats and at the JAM. And retroperitoneal fibrosis is a very important, and I think probably still neglected, area of IgG4 related disease. On the left here, one sees a classic radiology of retroperitoneal fibrosis with inflammation around the aorta. This is the aorta here, and this is the inflammation around the aorta. This is retroperitoneal fibrosis. It is a common complication of IgG4 related disease and still an area of great unmet need. So we're going to have a fireside chat focusing only on this. We have a couple of wonderful videos of patients and their caregivers who have retroperitoneal fibrosis, and we'll have a special guest to also help walk us through retroperitoneal fibrosis next month. Then to conclude the summer and to kick off the virus season, to get a step ahead of the virus season, we'll have an update on vaccines with Camille Cotton, who's a wonderful infectious disease specialist who consults regularly for the CDC. Vaccines are more important than ever. FDR, Franklin Delano Roosevelt, who coined the term fireside chat back in the 1930s, suffered from polio, a disease that we now no longer see because of effective vaccines. And there's more talk about vaccines now than ever before. So it'll be important for us to get boosters about our vaccine knowledge in August. And now I want to move to our conversations on treatment. And this is going to consist initially of 4 short videos, each of which is 3 to 5 minutes from that conversation that Arezou and Guy and I had several weeks ago in the Ether Dome. In between each segment, there will be one question that we will address. You've sent in a number of questions already, and we've interspersed these throughout the presentation. After we get through all 4 of the video segments, then we'll open it up to live questions. So let's get going with our first of 4 segments. Our warm-up here is the first quarter. So we want to talk about treatment of IgG4-related disease. Do you think every patient with IgG4-related disease needs to be treated, Guy?
I think it's a tough question, and we don't really know the answer to that question. I think the vast majority of patients do need to be treated. There is a small subset where it's a little bit more unclear, and it's mostly the patients with head and neck involvement primarily. So patients primarily with, for example, submandibular and parotid gland enlargement that might be asymptomatic. For some patients, that might be kind of cosmetically concerning, and that's a reason to treat. But for others, it might not. We don't really know what the long-term consequences of that are, how likely someone is to develop something like dry mouth as a result of that or not. So we don't know if those patients have to be treated. But the other challenge is it's also hard to know how many of those patients have involvement of other organs that we might not recognize, even if we look for it, doing imaging and labs and comprehensive physical exam. So in those cases, it can be more challenging. The reality is in most organs, if you let there be uncontrolled inflammation for a long time, it'll lead to organ dysfunction. So the vast majority of patients probably need treatment to prevent that from happening.
So let me ask you a couple of scenarios and see how you react.
Yeah.
So a patient with submandibular gland enlargement, not particularly troubling, not cosmetically problematic. Serum IgG4 concentration is normal or maybe just a little bit high, compared to the same patient who's got a serum IgG4 concentration that's 1,500, 20 times the upper limit of normal. Are you more inclined to treat one patient or the other, or does it not matter?
To me, the likelihood that someone has a serum IgG4 concentration of 1,500, if their only organ involved is the submandibular glands, that seems highly unlikely. And that's someone that I would assume that there's involvement in other places, even if I'm not able to prove it through my evaluation. So I'd definitely be inclined to treat that person. The person with isolated submandibular gland enlargement and a normal or mildly elevated serum IgG4 concentration, I would have a conversation with the patient about whether they are more inclined to treat or not. But if I were to not treat, I would at the very least be following up with them on a regular basis to make sure that I'm looking for other new areas of involvement and seeing how the disease kind of tracks over time.
So would you do any particular kind of investigations in such a patient to make sure there wasn't disease in other areas?
Definitely. I completely agree with Guy that when there is one organ involvement, you should look for other organ involvement and make sure the disease is not affecting them. So I usually do a CT scan of their body, chest, abdomen, pelvis, in some cases, if needed, even head and neck, just to make sure there are no other organs that are not asymptomatic that I'm not aware of. Honestly, that question would have been answered differently if we had treatments that the harms and benefits of them would weigh more toward the benefit. And the reason that we are even talking about if everyone should be treated is because we don't have a very safe medications available. Otherwise, I think all the patients with IgG4-related disease, if they are treated, we and the patients feel more comfortable of not waiting and checking them every 6 months, every year to make sure there is no additional organ involvement or damage accumulating. But at this point, with what we have, each time that we make a decision to treat a patient or not treat them, we are really weighing the harms and benefits of the available treatments for that specific patient. So when there is just one organ involvement and the serum IgG4 is not showing us that the burden of the disease is so high that in the next 6 months is going to affect another organ, I can hold off with warning symptoms and sign to the patient that if this happens, let me know immediately. And if there is elevated IgG4 in the serum, that means that there are probably plasma cells somewhere else other than the submandibular gland that are producing that IgG4 that I would like to find them by a scan and treat the patient.
And this discussion really, I think, has to acknowledge that we don't know enough about the natural history of some patients. If the patient truly only has submandibular gland enlargement, what is their oral health going to be like in 15 or 20 years? The submandibular gland produces 70% of the saliva after food is ingested. So saliva is very important for normal oral health, for normal teeth. And we need to know more about the long-term prognosis of such patients if the submandibular gland is the only organ that is ever involved, and we just don't know that yet. I am more inclined to treat patients than not, but you're absolutely correct. It's one has to weigh the risks versus benefits when we decide to approach treatment. So that conversation raises a very important point. The importance of a conversation between the patient and the clinician in deciding how or if to treat a patient. And we really wanted to begin to give you a glimpse into our minds of all of the things that we think about when we were deciding what to recommend to you with regard to treatment. We have one question that I want to address in just a second, but Arezou, let me ask you just a quick follow-up question prompted by something that you said. You talked about CT scanning and to assess the extent of disease. How frequently do you repeat CT scanning? Do you have a standard approach to that?
That's a great question, John. I can tell you that there is no evidence in terms of standardizing the frequency of a scanning of the patients that we have. And as you said, it all goes back to learning more about the natural history of the disease and progression of the disease. And we are hoping with the studies that are on the way that we learn more about that. But currently, I make a decision based on the patient's presentation, and not only clinical presentation, the serum IgG4, IgE level, C3, C4, in terms of how systemic their disease is. But most of the time when I see a patient, I do imaging of their body, CT, chest, abdomen, if there is any involvement on physical exam on the head and neck, that would be their baseline. And most of the time repeat that in a year. Sometimes the patient may require to do it a little even sooner if I want to evaluate the response to their treatment. But the first 3 years I usually do yearly for just a screening to understand if there has been progression of the disease. After that, based on their again, serology, the level of the IgG4, IgE levels, and their clinical response, I may decide to do it every 3 years.
Okay, thanks very much. So let's go ahead and address one of the questions that has been submitted, and this is from a caregiver. And honestly, I found this very poignant. I'm a caregiver for my 18-year-old brother who has confirmed involvement with IgG4-related disease in his pancreas, asymptomatic as of now, and bile ducts, probably. Liver function tests are increased. The liver function tests always respond to ursodeoxycholic acid, UDCA, which is not a term we've used on Fireside Chats before, so I'll say a word about that. The patient is currently on wait and watch and wait. So beyond the ursodeoxycholic acid, no other treatment is being administered. So I want to say a word, just a quick word about ursodiol or ursodeoxycholic acid. This is a medication which is actually a naturally occurring acid which is found in bile, which is the stuff produced by the liver, which helps us digest certain kinds of foods. And for more than 100 years, doctors have used ursodeoxycholic acid to treat a variety of things. It's used to treat certain kinds of gallstones, and it's also used to treat certain inflammatory diseases of the bile ducts. Primary biliary cirrhosis and primary sclerosing cholangitis are diseases in which ursodiol is used. The way that it works, if it works, is not entirely clear, honestly, and this is not a medication that we typically use in IgG4-related disease. But I would surmise that this patient, this young man, is being treated by a gastroenterologist, and that's probably why he's on this medication. But the question continues, the caregiver's question, which is a sibling of the patient. I want to know, what is his long-term prognosis, given that his age is only 18? Do we send him to college or not? We're very worried and scared. Thank you. So Guy, I'll throw this over to you. What would you tell this 18-year-old young man's sibling about his long-term prognosis, assuming that this is IgG4 related disease confined to the pancreas and bile ducts? What's his prognosis?
So this is a really important question, and for better or worse, we tend not to see a lot of this disease in younger folks, though it certainly can happen. It is always scary at this kind of age to have a chronic disease diagnosis, and I think it's very natural to be worried. Fortunately, the prognosis of IgG4 related disease is very good. And most people should be able to, with treatment, should be able to live a relatively normal life and do all of the things that they usually would do if they hadn't ever gotten ill. Of course, there's exceptions to that rule. But particularly with the pancreas and bile ducts, damage can happen. We've talked in other fireside chats and elsewhere about things like pancreatic insufficiency that can happen from pancreatic inflammation or kind of longstanding buildup of the bile acids. But these are all things that can be treated. And the great news about IgG4 related disease is that we have excellent treatments that can really put it into remission. And so I would say, this sounds like a young man who certainly needs to be in close contact with his medical team. But I don't think that this would be a reason to prevent him from going to college or, continuing to flourish in other ways.
Absolutely, 100%. I couldn't agree more with all of that, Guy. And this young man is at a point where he and his family needs to learn as much as possible about IgG4 related disease and the potential treatments, and that is exactly what the foundation is for. So I hope they'll spend a lot of time on our website learning about IgG4 related disease and ask us questions as they come up. But I feel confident that this young man's going to do very, very well. Let's go on to our second video clip. So across the world, the cornerstone of therapy really remains steroids. So how do we approach steroids now? How do you use steroids? When do you use steroids? Do you ever use steroids?
I do. So as you mentioned, IgG4-related disease responds to steroid treatment very rapidly, and usually patients do great with initial treatment. We all know steroids have a lot of side effects, and patients with IgG4-related disease who have had their pancreas involved, they accumulate more of those side effects. Because of their age, they are more prone to develop osteoporosis on steroid treatment. I try to limit the length and dose of the steroid treatment, but most of the time I use it not only for the treatment, for proving my diagnosis, and until I am able to get them the other medication, which is a steroid-sparing agent, either the conventional steroid-sparing agents or the B-cell depletions. I usually start with a steroid and go on to other medications to be able to stop their steroid as soon as I can.
What I do sometimes, if I really think the patient probably should be treated, but I don't yet feel comfortable that depleting all of their B cells is the right thing to do now, sometimes I would give them a short course of prednisone. Maybe put them on 2 months of prednisone, taper off completely, don't leave them on prednisone. If they have a dramatic improvement and then they sustain that for a long time, then great. But if it doesn't help, or if the disease comes back very quickly, then I feel more comfortable with that it's probably the right thing to go on to something else, maybe B-cell depletion right now.
I agree, and I approach it exactly the same way. It's kind of a similar patient where it's a little bit of a judgment call as to whether or not to treat. I think those are the patients where a short course of glucocorticoids can actually be very effective and in many cases can keep them in remission for quite a while and potentially spare them more aggressive immunosuppression. But for the patients with extremely elevated serum IgG4 concentrations or many different organs involved or other risk factors for having relapses sooner, we know that treating with prednisone alone is just a temporary fix, and those patients are going to relapse. And when they relapse, we will often have to use the prednisone again, as well as start another medication. So in those patients, my general approach is to start with a steroid-sparing agent upfront.
So that's a point well worth emphasizing, I think, that the higher the serum IgG4 concentration, the more likely it is they're really going to need our best therapy, probably sooner rather than later. And sometimes it's best just to go ahead and treat them with that.
Agreed.
What about other scenarios, speaking about using steroids only? We've talked mostly about the things that rheumatologists might see, the submandibular gland, but what about disease in the lungs, kidneys, pancreas? Are there scenarios in which you would use only steroids to treat that kind of disease?
I don't think so. I think in majority of the cases that other organ involvement may evolve to dysfunction of the critical organ, I would consider, and of course discuss it with patient, to move on to a steroid-sparing agent, which most of the time is B-cell depletion. With the submandibular gland, you're completely right. The dysfunction of the gland can cause salivary dysfunction and not having enough saliva with dry mouth, but not more than that. With lungs, kidneys, pancreas, liver, the dysfunction can be really important for the patient. And for that reason, I usually start the discussion very early on, as Guy mentioned. As soon as I start them on the steroid, buying time to be able to get the approval of the medication or do the necessary testing to make sure that treatment would be good for them, I go ahead and do the treatment for them.
Usually by the time they come to us with pancreatic or kidney or lung involvement, they've already had disease for quite a while, because the disease has been flying under the radar screen for a while. So they may already have some kidney impairment and some pancreatic damage. That is very, very common. And I'm really not happy just sort of letting that play out, seeing how they do on a little bit of steroid.
And flare again.
Right, yeah, I'm ready to put the fire out definitively as soon as possible.
And as I said at the beginning, we don't know when they're going to flare because many of these patients do not have symptoms. And if you are scheduling them to come back in 3 months or 6 months, they may be flaring 2 weeks after they saw you. And you don't want that activity go on and cause more damage to the organ. Some of the organs, as you said, already have some damage. They can't afford to have another flare.
Right. So you mentioned B-cell depletion, but is there anything between steroids and B-cell depletion? So do you use DMARDs, for example, at any point in your practice?
Many people do. I personally rarely use conventional synthetic DMARDs in my practice, mostly because our experience with them hasn't been all that promising. Some patients might have a decreased rate of relapses, but it's not nearly as universal, where patients will have a good response to conventional DMARDs as they would to rituximab and prednisone. And usually by the time I'm thinking about using a steroid-sparing agent, as you mentioned, I want to put the fire out, and I want to know that the fire is out. It's a very difficult disease to know exactly when the disease is still active and exactly when it's in remission. And that makes using a conventional synthetic DMARD challenging because it can be really difficult to know if it's working or not. And if it's not, then you could be exposing the patient to quite a long time where they have ongoing inflammation in internal organs and worsening damage, and you may not even realize it. So once I decide that I need to treat with something beyond glucocorticoids, my preference is to be able to completely put the fire out.
Right. So the DMARDs haven't been studied well in randomized double-blind placebo-controlled trials in this disease. There have been anecdotal stories of success, and I've seen them too, where mycophenolate mofetil, for example, seem to work well. But I always have the nagging sense that methotrexate and azathioprine and mycophenolate mofetil and others seem to be working only as long as the steroids are on board. And if you take the steroids off, then it's very clear the disease is relapsing, and those DMARDs really weren't doing very much all along. And it is important to remember that the disease tends to affect middle-aged to elderly people, though it can affect people across the age range, even kids. But it also is a disease that tends to affect the pancreas, and having to give these patients steroids with the implications for poor glucose control and for osteoporosis, that's really problematic. So the sooner we can get patients off steroids, I think that is important. DMARDs seldom help us do that. And I think patients are better off if we reach for B-cell depletion sooner rather than later. So that clip, I think, shows some important thought processes about steroids and how thankful we are to have steroids to use when we need them, but how happy we are to get patients off steroids completely as soon as we can, whenever we can. And I do think we are now in a new era of therapy for IgG4-related disease in which we can greatly minimize the amount of steroid that patients have to take. The second major focus in that segment was DMARDs. And I should have said before the segment what DMARD stands for. It stands for Disease-Modifying Anti-Rheumatic Drug. And these DMARDs include medications such as methotrexate, azathioprine, and mycophenolate mofetil. And the overall flavor I think that you get from that segment is that none of the three of us is particularly enthusiastic about the effectiveness of DMARDs, even though they're medications that have been around for a long time and are used frequently. None of us really thinks that they work very well and would be better served to move along to other therapies most of the time. Here's a question about steroids that was submitted before. I'm starting my first treatment beginning with prednisone, 40 milligrams for 3 to 4 weeks before getting a scan to see if tapering can occur. I haven't seen a common initial treatment level and wonder whether there is a best practice to follow for the dose of prednisone to begin and a timeline for taper. Arezou, how do you approach the use of steroid in a typical patient? What do you usually start with? How long do you leave them on it for?
So first of all, this is a great question, and unfortunately, in general in rheumatology, there is not great consensus among rheumatologists in terms of how to treat patients with a steroid, how to taper it, what's the exact dose, because we need the studies to really understand what is the best way to do it, and none of these studies has happened. My practice based on the guidance management that was also more opinion-based in 2015 that experts wrote that guidance. I usually start 40 milligram, which is most of the time 0.5 milligram per kg. One of the audiences asked that question in the Q&A. So it's really 0.5 milligram per kg. And I taper it over 8 weeks. I taper 10 milligram each 2 weeks. Most patients in the first 2 months period of the tapering respond very well, and their disease, the fire is out, the disease goes to remission. The question is after you decide to stop it right at the 8 weeks of 10 milligram that they may flare back. So if the patient's disease affects major organ and I worry that they're going to flare right after the 8 weeks, I may taper them to 5 and transition, bridge it with another medication. There are patients who have comorbidities, for example, underlying diabetes that is not well controlled. I even modify these 8 weeks and shorten it with bridging to B-cell depletion.
So that's great, Arezou. It's also, I think, important to acknowledge that the practice for the use of steroids has varied across the world. In Asia, in Japan, where the disease was first recognized, the tendency has been to leave patients on steroids on a low dose chronically for several years, many years, 5 to 10 milligrams a day. In contrast, in North America and in Europe, we've tried to get patients off steroids completely within a couple of months, as you suggested. Let's go on now to the third quarter, which is B-cell depletion. Before we do that, I thought it would be worth saying a quick word about what B-cell depletion is. This is a term you've heard us toss around all the time. So what are we talking about when we say B-cell depletion? B cells, B lymphocytes, are a critical cell in the immune system. They do lots of different things. They perform lots of different functions within the immune system. One of the things they do, for example, is they make antibodies. B cells begin to develop in the bone marrow, and that's what this schematic shows here. B cells develop from stem cells, and very early on in their development, they have markers on their surface. They develop a marker very early on called CD19, and then later on in their development, they develop CD20, another marker on the B cell surface. And after their initial development in the bone marrow, these B cells, which are growing up to be mature cells to learn how to make antibodies against specific targets, the B cells migrate out of the bone marrow and they go to the lymph nodes and other parts of the body where they continue their education to become fully informed B cells. And then eventually they migrate back to the bone marrow where they become plasma cells and live for a long time, making the antibody that they've learned to make. So this is a schematic, a little bit simplistic, of a B cell, of a B lymphocyte. And there are two markers. Again, just to reemphasize this point, there are actually lots of markers on B cells, but two of them that have been targeted for therapeutic purposes are CD19, which is a protein that sticks off the B cell surface, and CD20. And scientists have developed antibodies to target these markers. For example, Inebilizumab is an antibody directed against CD19. And when Inebilizumab, the medication approved just in April for the treatment of IgG4-related disease, when Inebilizumab binds to CD19, it marks the cell for destruction. So the remainder or other elements of the immune system will identify this antibody attached to CD19 and destroy that B cell. And if the B cell is behaving badly and contributing and driving the inflammation of IgG4-related disease, then that is a good thing. There are other antibodies, other monoclonal antibodies directed against CD20. That would be Rituximab, for example, and there are others. When we talk about B-cell depletion, it's important to realize that we don't deplete the body entirely of B cells. That wouldn't be good. We wouldn't want to do that. But these medications, which are highly effective for the treatment of IgG4-related disease and others, do deplete the blood of B cells. So for a period of time, for 6 months, for 9 months, for 12 months, B cells cannot be found circulating in the blood. There's still plenty of B cells in lymph nodes and other areas. They're just not circulating in the blood. And depleting cells from the blood can have a remarkable effect on the treatment of disease. So that's what we mean by B-cell depletion. And when we give a specific antibody against anti-CD19 or anti-CD20, then we deplete the blood of all of the B cells that have that marker on their surface. And again, it leads to a dramatic therapeutic approach. So let's look at our conversation about B-cell depletion.
So how do you approach B-cell depletion with these patients?
Well, I would also add to what you just said that the other benefit of using B-cell depletion as opposed to any other option is that B-cell depletion is the only approach that we know works and that has actually been studied and shown to work in the absence of concomitant steroids. So in patients who don't have imminently organ or life-threatening disease, which actually is a decent number of patients considering how indolent the disease is, I very often will use B-cell depletion alone without needing to use any glucocorticoids. And that spares the multiple months of glucocorticoids that can lead to significant toxicity in many patients.
It was really compelling that when we finally had the opportunity to do a randomized, double-blind, placebo-controlled trial and see the degree to which B-cell depletion reduced the risk of flare, 87% reduction in disease flare, and a dramatic decrease in the amount of steroids that patients had to take after they stopped their taper. It wasn't even close. B-cell depletion is so much better than a course of steroids that stops after a couple of months. So I think that's right. Now we finally have randomized, double-blind, placebo-controlled data that that's correct. But there's no free lunch because B-cell depletion does come with potential complications, and these were driven home to us in spades during the pandemic. So what do you tell patients about the risks of B-cell depletion in this era when there's still quite a few viruses around and maybe some we haven't learned the names of yet?
Exactly. So I explained to them that B-cell depletion takes away all their B cells, which is a critical cell in the immune system. And it's very important for defense against the germs, viruses, especially the ones that they have not been exposed before and they do not have memory cells or the plasma cells that respond immediately and produce antibodies. It's important for them to know that they may not respond to vaccinations while their B cells are gone. It makes them more prone to get those infections and more severe type of infections. And repeated B cell depletion can also cause hypogammaglobulinemia, which means their immunoglobulin levels, the antibodies that they have to produce to fight the germs, will be low. And in some cases, we all have seen repeated hypogammaglobulinemia due to their B-cell depletion. They may require to receive IV immunoglobulin for their immune system. So those are all the side effects that I explain to them. But on the other hand, I explain to them that the other option is a steroid, which has probably more side effects compared to the B-cell depletion.
So I think we need to have these conversations with patients. And of course, the pandemic made us realize the importance of vaccination and being on top of all of those things. But once we've ticked all those boxes and they've had their COVID vaccines and their COVID boosters and their flu shot, their pneumonia shot, their shingles vaccine and their RSV vaccine, if that is appropriate, we should go ahead and treat and monitor carefully, but control the disease, put the fire out as quickly as possible.
Timing of those vaccines with their repeated B-cell depletion is very important, and it's possible and doable. We are doing it in other diseases, and for IgG4-related disease, we should be able to do that.
One of the things that I've learned from some of the Foundation's Fireside Chats is that our infectious disease colleagues often re-immunize patients who have received B-cell depletion every 6 months. So if a patient has gotten B-cell depletion, even if they had been vaccinated before or hadn't been vaccinated, go ahead and vaccinate them and then give them a booster every 6 months, because that may contribute to immunity through other mechanisms. But it's very important to try to keep a careful eye on the choreography and the timing of vaccines with regard to treatment. Ideally, we want to vaccinate patients 3 or 4 weeks before they get B-cell depletion.
So I want to highlight one of the things that Guy mentioned, and that is the ability to treat patients essentially without steroids, to nearly eliminate completely the use of steroids in patients with IgG4-related disease now. with an infusion of Inebilizumab, patients will receive some steroids. That's always given with each infusion. But the way the field should move, I think, the way the practice should move, really should be toward minimizing getting rid of steroids completely. With our new therapies, such as B-cell depletion, I really do believe we're going to be able to do that. A point that Arezou mentioned, which is so important, is the critical need to choreograph vaccination with treatment. And in order to choreograph it, you've got to be keeping up with the dates and the timing of your infusions and your vaccines. And I would point out here that IgG4 Me, the app that the foundation is releasing in the latter part of this month, can be very helpful in doing that and having all of your information about what you were vaccinated against and when you were last treated with B-cell depletion. It can be very helpful to have that when you're at your doctor's appointment. So stay tuned for more about IgG4Me. Let's move on to a question now. So here's a question submitted in advance by a person with IgG4 related disease who says, I am currently taking MMF, mycophenolate mofetil, 1,000 milligrams twice a day, and am still on prednisone, 5 milligrams a day. So far, I'm okay and anticipate being off the prednisone soon. Great. I saw a rheumatologist and will have the option of using Inebilizumab if needed. I'm getting my vaccinations updated now. Great. So there are a couple of questions. One, is Inebilizumab a better drug to take than Rituximab, another B-cell depleting agent? And number two, do I have to take B-cell depletion every 6 months for the rest of my life? So with regard to the first question, I'll tell you what I tell patients when I'm asked this question, because I'm given this question often, and I'll be interested to see what Arezou and Guy think as well. In stacking up Inebilizumab to Rituximab, two different B-cell depletion strategies, I tell patients that Inebilizumab is a newer agent. It's already approved. It's approved for two diseases now. It's what we call a humanized antibody, by which I mean that Inebilizumab is very much like the antibodies that we make. All humans have antibodies as part of our immune system. So Inebilizumab is very, very close in structure to our own antibodies. In contrast, Rituximab is what we call a chimeric antibody, and it's made partly from mouse amino acids. And the mouse amino acid component of Rituximab is more likely to lead to problems caused by antibodies developed to the antibody. And it can lead to infusion reactions and a loss of efficacy and things like that over time. It doesn't happen in a lot of patients treated with Rituximab, but it is potentially an important issue. The second thing is that Inebilizumab targets probably a broader array of B cells because it targets CD19, which is expressed on a larger percentage of B cells. So it may also be more effective. I was very impressed by the safety data on Inebilizumab from the Mitigate trial, in particular with regard to COVID. The Mitigate trial was done at a time when most patients in the trial were not vaccinated against COVID because there was not a vaccine available when the trial began. So 70% of patients were not vaccinated. Yet there were no more infections, COVID infections in the Inebilizumab group than in the prednisone-only treatment group, which I was surprised by and very delighted to find. Guy, Arezou, does either of you have any other thoughts about the Inebilizumab versus rituximab question?
Sure, I'll share some thoughts. And I just emphasize that everything that we're talking about with comparing these two is really all theoretical because there's never been a study that's compared rituximab versus inebilizumab. So it's all based on kind of how they theoretically work and what our clinical anecdotal experience has been with the two. But I agree with everything you said, John. I'd add a couple of things. Because it's fully humanized, the infusion time for inebilizumab is substantially shorter. It can be given over about 2 hours or so, depending on the protocol for the infusion center, as opposed to more like 4 to 6 hours for rituximab. So I've had a lot of I've spoken with a number of patients who that really makes a big difference for them in terms of the amount of time that they have to dedicate to being in the infusion center. But I'd also add, kind of being the devil's advocate of it is newer, and it takes, generally speaking, it takes time to really understand what a drug's long-term safety profile is. As you mentioned, John, inebilizumab has been used for a few years now for NMO spectrum disorder, a neurologic disease, and has a favorable safety profile so far, but it is a much younger drug than rituximab. So we're very aware of the long-term risks associated with rituximab, and Arezou mentioned some of those in the conversation. And it is possible that it's just too early in the story of inebilizumab for us to fully understand those same risks.
And I completely agree with both of you. And I tell my patients that it's an upgrade from an older medication that we know it works. We know rituximab works. But as Guy said, we never had studies comparing these two together to see which one is superior to the other one. Rituximab works. We are seeing that inebilizumab in the clinical trial performed very good compared to other studies. This is an amazing result that we have received, and probably for patients, because it's depleting B cells, and when you showed the schematic in the evolution of the B cells, wider range of the B cells are depleted by the inebilizumab. So I'm hope that it would put them in the longer term remission, or the response would be a little deeper than rituximab. But overall, both of them work well.
All in all, if I had to recommend a drug for my brother, whom I love very much, I would be absolutely delighted to give him inebilizumab if I had to. But it's nice to have effective medications. The second question, do I have to take B-cell depletion every 6 months for the rest of my life? What is your approach to that, Arezou?
So that's individual patient. I wouldn't say that every 6 months at all for patients with IgG4 related disease. I usually do not schedule them for 6 months after their initial one. I evaluate the response to the first treatment. Definitely immunoglobulin levels need to be checked. Some of my patients, depending on their age, depending on the load of the disease or load of the B cells that they had, sometimes they stay in remission for 9 to 12 months, even longer than that. But some patients require it every 6 months. So that is the key, to check the patient and not have them on every 6 months, because actually repeated infusions of the B-cell depletion, usually more than 4 or 5 times, is when the patients get into trouble with hypogammaglobulinemia, at least based on my experience.
Okay, we have a question that's been sent in about hypogammaglobulinemia, and we'll get to that in time. But let's go on to our final segment here. Let's talk about treatments that are on the horizon.
I wanted to switch to treatments that might be just over the horizon, because there are some things that are now in clinical trials, and we're eagerly awaiting those results. So what are you excited about, Guy?
So I think B-cell depletion is great, but I think we've just covered that there's a lot of potential risk to it. And I think what we really need in this disease is an option that works as well or close to as well, but gives us a more favorable side effect and risk profile. So the first trial, international multi-center randomized controlled trial, phase 3 trial, was published in 2023, and that was for a B-cell depleting agent. The second trial is currently ongoing, and that is for a drug called Obexelimab, which is, rather than a B-cell depleting agent, a B-cell down-regulator. But hopefully it'll mean that it'll work in a similar way because it's targeting similar cells, but will be more reversible in case someone does have an infection or needs to come off the drug for any reason. And hopefully will be less immunosuppressive and have a smaller risk of infection. Only time will tell if all of that will be true. I think the thing that we're all really hoping for is something that we can use to treat patients reliably, but have a better safety profile than the options that we have now.
It's really cool biology, the drug binding to CD19, like some B-cell depleters, but also having another part of the antibody that binds to Fc gamma R2A or B. When those two proteins are ligated at the same time, the B cell is downregulated. And so that's really elegant. And we'll have to see how the drug performs. There's no better way to know how the drug really works than a randomized double-blind placebo-controlled trial, and we'll have those data soon. And it could offer significant advantages. And it's also nice for patients to have a choice. IV might be preferred by some, but subcutaneous administration that can be given at home also certainly has its advantages.
Definitely. In addition to the mechanism, as you mentioned, having options of modalities, IV version, which is every 6 months to weekly, that they can stop. And if they have an infection, to just give a break to their immune system would be amazing. PO or the pills that they can take by mouth if patients are not comfortable with injecting themselves or getting the infusion. One thing that we forgot to mention is the infusion reactions that can happen with these monoclonal antibodies. And we all have seen patients that are sensitive and can't get a specific medication through the IV. So it would be really great to have other options.
Right. And another possibility is even an oral option. So the BTK inhibitors, which work really well in treating lymphoma, a number of them are approved. Lymphoma is a pretty aggressive disease. So one would like to think that there's a BTK inhibitor that would be useful in IgG4-related disease. We participated in the phase 2 rilzabrutinib trial, which was completed not too long ago, offering possibly an oral option.
And there are so many other smaller trials that are ongoing in different parts within the country and the world, everything from JAK inhibitors to other conventional synthetic DMARDs and other biologics. So there's a lot potentially on the horizon. I'm very excited to see how it all shakes out. I do think one thing that would be wonderful in the future, which I think is a number of years away, but hopefully something that we can think about, is a cure. Because everything that we're talking about is to manage the disease in the short term, but if you stop it, the disease comes back. And we're now seeing with the evolution of CAR T therapy for different autoimmune diseases, the theoretical possibility that we might be able to cure certain autoimmune diseases. And if we can find something that does that in IgG4-related disease, wouldn't that be great?
Yeah.
I'll be happy with long-term remission if we don't call it even a cure.
Yeah, long-term remission is great. And if you remit for long enough, you can call it a cure for all practical purposes. I'm really excited about a cell-based therapy. I do think the CAR T therapies, the CAR NK therapies may have their use in IgG4-related disease since the B cell is such an important cell. There is a new trial that is starting of a cell-based therapy. The drug doesn't even have a name other than ACE-1831 at the moment, but it capitalizes on really unique, innovative, Nobel laureate winning chemistry. It's click chemistry. Carolyn Bertozzi won the Nobel Prize in 2022 in chemistry for her invention, discovery of click chemistry. And click chemistry has been adapted now to take a gamma delta T cell and attach no fewer than 100,000 rituximab molecules to each gamma delta T cell. And then the hope ultimately, after preliminary dosing studies, is to be able to infuse up to 1 billion of these cells. And I think that's going to be really interesting to see the impact on disease, duration of response, duration of remission. And it's possible that the drug won't need a lot in terms of lymphodepletion, which is a big issue in some of the CAR T and CAR NK therapies.
Definitely. The exciting thing about this treatment is that the gamma delta T cells may carry rituximab into the tissues that are the main reason for this disease. So not only works in the blood circulation and really would eradicate the disease from the tissues, and that would be really amazing for long-term remission.
Yeah, and it's an allogeneic cell too. So that also has advantages with regard to speed of preparation. It can be an off-the-shelf preparation. So exciting times ahead. And we all need to continue gaining clinical experience. I learn something every day in clinic about these patients. They're nuanced, they're individualized, but we have an increasing array of therapies to bring to bear on them, and it's a very exciting time.
So I think you can sense the feeling of excitement that we have about what is just over the horizon for treatment of IgG4-related disease. And Guy even mentioned the possibility of cure, and we hope that is not too far away either. We can go ahead and move on to questions, additional questions now.
There are about 6 questions in Q&A if
Great.
you want us to read. One patient is asking if an IgG4-RD patient with known head and neck involvement, submandibular gland, cervical spine, is experiencing jaw pain, what would a doctor need to consider to determine if this is IgG4-related disease versus TMJ disorder? Guy, you want to take that?
Always tough to answer, kind of very specific questions about a patient's presentation without having all of the details. But the couple of things that I'd mention are, I don't think of jaw pain as a typical symptom of IgG4-related disease. That doesn't mean that it can't be, but it is, common things being common, it's much more likely that someone's jaw pain is from something like TMJ disorder rather than it being related to IgG4-related disease. But it is within the realm of possibility. So I think it depends on how exactly it's presenting and whether there's features of it that suggest that there's that there's reason to believe it's not TMJ or one of the other common causes of jaw pain. But rarely there are situations in which, particularly when there's involvement of blood vessels in IgG4-related disease, when it's a vasculitis, it can cause a presentation where, because of inflammation of blood vessels of the head, there can be loss of blood flow to the jaw muscles, which can cause some jaw pain or fatigue with chewing. And there are other kind of theoretical reasons why someone might have jaw pain with IgG4-related disease, but I would say that that's very rare and probably more likely that it's just an unrelated problem.
Someone is asking, I've had rituximab 1 time. How do you feel about switching to Uplizna?
That's a question I get a lot. And as I indicated, if I can get a Uplizna approved, then that would be my choice because of the lower likelihood of an infusion reaction or the occurrence of serum sickness and the very good side effect profile that Uplizna has shown so far. So that would be my choice. It's an individual patient decision, and that's a conversation between patient and physician about what to do. But I've been typically making that move to INEB, as we call it.
One person raising their hand if you'd like to take a live question.
Yeah, let's do that. That's great.
Okay, let me unmute them.
Awesome. The question I have really quickly, you guys were discussing B cell depletion treatment and wanting to make sure you do not completely deplete all of the B cells. Is it important to monitor your B cell levels so as to make sure they don't completely deplete?
What a wonderful question that is. That is so great. And we're probably gonna have a special fireside chat before the end of the year. All the questions about B cells you wanted to know but were afraid to ask. So thank you for asking that question. The chief scientific officer at Genentech some years ago told me it is impossible to fully deplete the body of B cells. So you can't give enough Inebilizumab or Rituximab or anything to fully deplete the body of B cells. And that's good because we don't want to do that. When we give one of these medications, we very reliably and predictably fully clear the blood of B cells within a couple of weeks, probably faster than that. You give a dose of INEB and the B cells are gone from the peripheral blood. We don't even have to measure because it just works essentially in all patients. Where we are not good is, or an area it would be wonderful to have more knowledge in, is how deeply we have depleted the B cells, because we know they're going from the blood, but they're in lymph nodes, they're at sites of disease potentially, and we're not good, we don't have the capability of measuring how deeply we've depleted the B cells. I hope that makes sense. Arezou, Guy, feel free to elaborate on that. And if the questioner wants to ask a follow-up question about that, if that didn't fully address it, then please let us know.
I think you answered the question exactly the way that I would. The only thing that I would add is I've seen some of my colleagues check the B cell numbers in the blood to make a decision if patient needs to receive B cell depletion again or not. I don't do that because I don't see, especially in IgG4 related disease, much correlation between disease activity and the number of B cells that are coming back after 6 months. I do have many patients whose B cells come back to normal after 6 months, 9 months, but their disease is pretty quiet. And I have some patients that just have 1 or 2 B cells in their blood that we can measure, but they have a very active disease in their pancreas. So as Dr. Stone mentioned, the return of the B cells in the tissues we can't measure. We don't have any way to measure that. So checking it in the blood is not going to be that helpful guiding us when is going to be the next treatment.
I agree with that. I also don't use regular monitoring of B cells to guide when to treat or to really understand disease activity. I think we have better biomarkers than B cells, but I do use them in 2 situations. One of them is if I'm trying to figure out when would be an ideal time to vaccinate someone. If I'm waiting after I've given B cell depletion, after a number of months, once the B cells are back, it's likely that the patient will have a more robust response to a vaccine. So I will sometimes check B cells on a regular basis to try to time when to do the vaccines. And then in the rare situation where someone might not be responding clinically to a B cell depleting agent, sometimes I'll check B cells after giving a B cell depleting agent to make sure that the B cells are actually gone. Because if they're not, then that to me suggests that the body has kind of become immune to that drug and that it's not the mechanism of B cell depletion that isn't working, but it's that specific drug. And that's something that we don't see often, but we can see, particularly with rituximab, as John mentioned, since it's a chimeric antibody rather than a humanized antibody.
So that was such a great question, and I want to thank the questioner for asking it. And I just want to emphasize it's very logical to think that since we're depleting B cells for the purpose of treating, then if we measure B cells again, then that would be a useful index of when we need to treat patients again. But that's not quite right, because the B cells can still be causing problems again, even if they're not detectable in the peripheral blood. And we're not good at measuring the concentration of B cells in tissue. I imagine we'll get there at some point in the next few years where we're better able to do that, but it's been an issue for as long as we've had B-cell depletion therapies. So terrific question.
Is it common to hit the disease hard using mycophenolate and rituximab?
Yeah, this is something that I've seen done. Personally, I've never done it, and that's only because I've never needed to do it. The nice thing about rituximab and Inebilizumab is the predictable and reliable response that patients will have, to the extent that if someone doesn't go into remission following a good treatment with B-cell depletion, it makes me question the diagnosis. So it's very rare, if at all possible, that someone would still need something on top of the B-cell depletion. So where I've seen this done most is in patients who initially were treated with mycophenolate or some other conventional DMARD, and the disease didn't fully go into remission. So then a B-cell depleting agent was added on top of that. And my approach in those cases is to stop the conventional DMARD, because usually it's just not needed. The B-cell depletion alone is usually enough to keep the disease in remission.
Go to the next question. I want to go back and pick up this question, which we skipped over. So this person asks, in between infusions every 6 months, I always start to decline before then. Besides steroids, what are my options? So this is an issue that I do encounter sometimes. I think there are a number of things to think about. Number one, there is no perfect answer to this question, and the correct answer probably varies for each individual patient. There may be some patients who do need to be treated more often than every 6 months. That's certainly true in other diseases, and I've seen some patients with IgG4-related disease who need to be treated with B-cell depletion more often than every 6 months. So sometimes I do that for a while, maybe give them an infusion of a B-cell depleting agent every 4 months for a while, and then back off and start to widen the interval again. The second thing to think about is it possible that there is something other than IgG4-related disease that is leading to the patient not feeling so well? And of course, there are a whole variety of things that might be. There could be adrenal insufficiency, for example. So poor sleep. Some patients suffer from sleep apnea, and sometimes correcting a sleep apnea problem can help patients perk up as well. As I said, there's no perfect answer to this question, so I'm curious to whether Arezou or Guy has another thought about how to approach this.
I agree with you. It depends what the decline is. So identifying, is it really activity of IgG4-related disease, or is it just something else contributing? Definitely different answers can be given to this question.
I agree. The one thing that I'd add is also thinking about the timeline of when that decline happens, because in the question it says well before then. If well before then means 2 to 4 weeks before the infusion, then that's kind of stronger evidence that it might be that the B-cell depletion is wearing off, and maybe the more frequent infusions, as John mentioned, are needed. But if it's, the decline happens 2 to 4 weeks after the last infusion, that really isn't consistent with how the infusions work. So that really makes me question whether there's something else going on. And something that I always remind patients is, with every infusion of B-cell depletion, you also get a dose of steroid. And steroids will help with IgG4-related disease, but they'll also help with a lot of other things. And a lot of people just feel better when they're on steroids. And after a couple of weeks, those doses of steroids kind of leave the system, and sometimes people feel worse again after that. So just keeping in mind that there are a lot of things that can contribute to these symptoms.
And the final thing I would add is mood. A lot of times there can be a mood disturbance that is making a person not feel well, and addressing that directly can also be very helpful.
We have one question that I think is a tough one. is angiocentric fibrosis similar to IgG4? I think that's one that's referring to angiocentric eosinophilic fibrosis, which is a term that was put out into the literature maybe a decade and a half ago, around there, or maybe a little bit before then. I don't know, Arezou, do you want to tackle that and talk about how it relates to IgG4 related disease?
Yeah, we actually published at Mass General cases of eosinophilic angiocentric fibrosis that the histology and immunostaining was consistent with IgG4 related disease. They may be considered a subset with more eosinophilia, more allergic and asthma type reactions. So full history of eosinophilic angiocentric fibrosis could be a little different from IgG4 related disease, the way that we know as a systemic disease, but the response to treatment is mostly similar.
I agree with that completely. One of the patients we described in that paper, published back in 2009 or 10, when you were a fellow, Arezou, we now follow as IgG4 related disease, and he's morphed completely into a patient who looks exactly just like IgG4 related disease. So I think it is a subset, and they're a little bit different in terms of risk factors. But in terms of treatment response, it responds just like IgG4 related disease most of the time. There's one other question here. We are at a loss as to what treatment options to explore. And let's see, I can't quite read this fully. And how to ask the physician what is working and what is not. It's been difficult to know whether anything has worked so far. Steroids, rituximab, and MMF have been tried. What are the typical markers that a physician looks at when determining the efficacy of a certain medication, steroids, infusion therapies, etc.? Is it a combination of IgG4 blood levels, shrinkage in the size of lymph nodes, masses, changes in the radiology findings, patient self-report, or other? So, Guy, how do you determine whether a patient has responded to therapy?
That I think depends on how the patient initially presented. So I use a combination of symptoms, physical exam, often imaging, and often labs. So in someone who has a lot of symptoms from their disease at the beginning, at baseline before treatment, or if they have enlarged glands of the head and neck or other manifestations that I can pick up on physical exam, then I follow those things and make sure that they get better. In people who have elevated serum IgG4 at the start of the disease, or who have low complements, or who have labs that are associated with organ function. So, for example, if the lipase, a marker of pancreatic inflammation, is elevated, or if the kidney function is reduced, I'll follow all of those things to make sure that those things get better after treatment. I also very often will use imaging, and I use imaging especially in people who have internal organ involvement, especially if that internal organ involvement is asymptomatic. And I rely even more heavily on imaging in people who don't have lab markers of disease activity. So the most typical scenario where I'll use a lot of imaging to understand the treatment response is retroperitoneal fibrosis, where a lot of it can be completely asymptomatic, and many of these patients have normal serum IgG4 concentrations. So I'll use a combination of symptoms, physical exam, labs, and imaging. But I think one of the biggest challenges in doing this is differentiating between things that are still abnormal because of ongoing inflammation versus things that are still abnormal, either symptoms or labs or imaging findings that are a result of damage or scar tissue formation, fibrosis that's occurred in the places where there's involvement, and we see a lot of that. So I think one of the things to consider as you're following the disease over time is if things have gotten better and then have plateaued, even if you're using more B-cell depletion, or you try another short course of steroids to see if it makes a difference, and if everything stays exactly the same, then that's probably a result of damage rather than active inflammation. And it's important not to overtreat that.
And sometimes just keeping things the same is as good as we can do at the moment. So I think that's a very good point. If there has been a lot of damage, then just preventing further damage can be success. That is what success looks like in some patients. So let's take another couple of questions. Is there one or two others in the Q&A?
So one person is asking, what would you expect the use of B-cell depletion to have beneficial effect on concurrent RA disease, rheumatoid arthritis?
Oh, that's a great question. So B-cell depletion therapy is an approved therapy for rheumatoid arthritis. I've seen it work extremely well in rheumatoid arthritis. So I would anticipate that if anything, it would have a beneficial effect on rheumatoid arthritis. Nothing works for all patients with rheumatoid arthritis, however. So some therapies work extremely well, but in rheumatoid arthritis, one has to find the right therapy for the right patient. But B-cell depletion might work very well for.
Interesting question here that I'm interested in your thoughts about. Have you seen success with pancreas transplants in patients who have no function of the pancreas or prefer islet transplants?
Oh, that's a great question. I don't have a lot of experience there. Do you, Arezou?
No, I don't. I have a patient with IgG4-RD who had liver transplant, but not pancreas.
The field of transplantation has been progressing so fast that I think there will be some very exciting things in that. Pancreas transplants haven't been done very commonly, but I think there will be much more creative approaches. For example, the islet cell transplant that the questioner mentions. Islet cells are the cells within the pancreas that make insulin. So it's not a full pancreas, but the islet cells perform a very important function of the pancreas, namely to make insulin and to facilitate glucose control. And there are a lot of advances coming there, I feel sure. Try to address them. Will I be able to get Inebilizumab in New Zealand? I believe that the answer will be yes. Drug regulatory approvals happen on different schedules. Inebilizumab was approved in the United States just in April. It will hopefully be approved in Canada this summer, in Europe, in the European Union, sometime perhaps early this fall, and in Japan later in this year, and in China, I think in 2026, if all goes according to our hopes. And I don't know what the schedule is for Australia and New Zealand, but I feel sure that that will be an option for patients living on New Zealand in the future.
A similar question was asked about India, so you answered it.
Yeah, I think the same applies for India as well. And Arezou, you mentioned hypogammaglobulinemia earlier. Do you want to take this last question? What is the risk of hypogammaglobulinemia in long-term B-cell depletion, and how can it be countered?
So it is an expected side effect from recurrent B-cell depletion, because as Dr. Stone showed in that cartoon, when you deplete or take away the B-cell and with repeated infusion, make sure that they stay away. So you are making your body deplete of the B cells that are supposed to make the immunoglobulins. And when the immunoglobulins are not made regularly by the B cells, so the level of the immunoglobulin, which is the total IgG, goes down. We are doing it intentionally to reduce the IgG4, which is the problem, which is confused and causes the damage to the organ. And with certain B-cell depletions, with repeat infusion of the B-cell depletions, in some patients it doesn't come back up after you stop it. We see that, and to prevent it, I usually check the IgG level before the next infusion of the rituximab or Inebilizumab, just to make sure that if the patient's immunoglobulin is already low, I don't want to give them further B-cell depletion. If that happens, that in some cases it happens even if you check their immunoglobulin level, there is a treatment that is supplementation of the immunoglobulin. It's called IVIG, and they can receive it to just kind of like replenish the immunoglobulin levels in their body to be able to fight with the germs and viruses.
So monitoring the globulin levels, globulins are antibodies, and monitoring these is an easy thing to do. And if it looks like a problem might be happening with hypogammaglobulinemia, then spacing out the infusions as much as possible can be a very good idea. And I want to thank Guy and Arezou very much for lending their expertise to this session, and I'd like to thank all of you for your participation and your questions. And we'll see you next month when we talk about retroperitoneal fibrosis. But be sure to visit our website and look for the launch of IgG4 Me just in the next 10 to 14 days. Thanks very much.